Today's topic, and good morning, everyone, or afternoon or evening. But today's lecture focuses on a skill that defines every great psychiatric clinician: the ability to think systematically during medication treatment planning and to structure your follow-up reviews with precision and purpose. One of the things I come across is when doing treatment planning, I usually find that I have to take a pause. I get stuck sometimes with a case, and I will do a more thorough review at that time and say to myself, why am I feeling stuck? This case does not seem to be progressing, and actually planning will save you a lot of time and wasted time for the patient's care. So as physician associates, your role is not just to hand out refills. You are co-strategists in the patient's recovery. Every follow-up visit is a clinical decision point, a chance to adjust, reevaluate, and refine. I mostly do this on a yearly basis with every patient. Instead of doing what we call an intake on every single year, it's best to take a pause and do a treatment plan. See what goals and objectives the patient has, and also be able to meet those goals for them and help them. Our objectives today are to design medication treatment plans that are evidence-based and receptor-guided, conduct structured psychiatric follow-ups that assess efficacy, safety, and function, integrate psychotherapy and education into each medication visit, document your clinical reasoning to ensure continuity and accountability. The PA's role in medication management. In psychiatry, the physician associate is the bridge between consistency and adaptation. Your tasks extend far beyond prescription renewal. You're responsible for monitoring medication efficacy and side effects, ensuring adherence and engagement, and reassessing diagnosis and safety, educating the patient in every interaction. Every visit should answer 5 clinical questions. Is this diagnosis still correct? Is this medication still working? Are there new side effects or risks? Is this patient adherent and informed? Is the treatment plan moving forward to recovery? And that's what you should be focused on, because each session is a chance to stop. And that's what I would definitely give you advice on. Components of a very robust treatment plan. A psychiatrist's treatment plan should be dynamic, hypothesis-driven, and measurable. Let's break down this step by step. Problem identification. Identify specific symptoms beyond the diagnosis. Insomnia, anhedonia, rumination, irritability. These become your treatment targets. Diagnostic formulation. Verify accuracy. What if anxiety is actually bipolar depression? Always rule out comorbidities. Medication selection. Base your choice on mechanism, receptor profile, and prior patient response. Goal setting. Use measurable metrics. PHQ-9, GAD-7, or mood charts. Define what success looks like. Even give some time to a patient when goal setting to discuss what their goals are. They might want to attain a job, and maybe these symptoms are coming in the way, but that should be your long-term goal with the patient if they're seeking employment, for example. Education and monitoring. Teach patients about expected timelines, often 3 to 6 weeks, and ensure they know what to watch for. A more educated patient is likely to help you in trying to determine what they need to tell you for next session. This is important. Many patients don't remember what they're taking, which is a burden on the clinician. And sometimes when they don't know what medications they take, they're often not adhering. And also, it's also a failure on the clinician side not to readdress and keep on questioning if the patient remembers what they're taking and what purpose they're taking it for. Those are important facts in trying to have a good treatment plan. A clinical example, let's apply this framework. A patient with bipolar depression and anxiety presents for treatment initiation. We choose lamotrigine for long-term mood stabilization without mania risk. Low-dose quetiapine for sedation, anxiety control, and minimizing switching risk. This illustrates mechanism-based reasoning. One medication for neuronal stability, the other for serotonergic and dopaminergic modulation. Why this combination? We all discussed in every single aspect of your treatment planning. You should always ask your questions. Why am I giving these medications to this patient? And explain. The structure of a psychiatric medication follow-up, I wish it was very loose, but it can actually be very succinct. And you can actually have a reproducible structure because we do have a good frame to live in within 25 minutes. Every psychiatric follow-up should follow that reproducible structure. You must be intentional with your time. For example, report and update, reconnect and assess how things have changed. How have things been since your last visit? A symptom review. Is your anxiety easier to manage day to day? Functional review. Real world impact. Are you back at work or socializing? An adherence check. Any problems remembering your evening dose? Side effect screen, symptomatic by body system, any changes in sleep, appetite, or energy. Risk assessment, suicidality, mania, any thoughts of hopelessness or impulsivity. A clinical decision, continue, titrate, or augment. Let's raise your dose slightly and review in 3 weeks. Education and plan, reinforce next steps. Here's what I expect with this adjustment. And I also go as far as to tell them what I'm thinking of next. Sometimes by telling patients what you think next is going to happen or what options they have to pick when in a session will help them realize that maybe they can even tell you on next session what you thought. Instead of digging through charts and figuring out what you said, sometimes the patient knows because you told them. And that's the best way to continue care and also to continue rapport. Phases of pharmacological treatment planning. I do tell my physician assistants there is 3 aspects to a patient. One, the acute phase, which is usually 0 to 12 weeks of treatment. The goal is always symptom remission and minimize side effects. And usually follow-ups are usually every 2 to 4 weeks. In the continuation phase, usually 3 to 9 months, relapse prevention and adherence, monthly visits to monitor function, and then a maintenance phase, 9 to 24 months. The goal is to prevent reoccurrence and reassess the need for tapering. Visits every 2 to 3 months with labs and metabolic checks. Your follow-up frequency should always reflect where the patient sits in this continuum. And an algorithmic approach for by disorder I listed here. For example, in major depression, you just start with an SSRI, switch or augment with an SNRI or appropriate, or even add an atypical aripiprazole or brexpiprazole if resistant. Consider TMS or ECT for refractory cases. Some special services, even esketamine, can be useful. But you have to look at the case and you have to make steps towards what your goals are for symptom remission. Anxiety disorders, begin with an SSRI or an SNRI, add buspirone or hydroxyzine, pair with CBT, avoid chronic benzodiazepine use. This is your opportunity to work on tapering benzodiazepines at a chronic or maintenance phase, because that means you're ready to start looking at other things and the benzodiazepine may not be as useful anymore. Again, an area to stop and think. Bipolar disorder, start with a mood stabilizer, lithium, valproate, lamictal. Never use antidepressants alone in those cases, and consider adding an atypical, quetiapine or luprazidone. Whatever the patient's symptomatology, you pick the appropriate agent. Psychotic disorders, atypical antipsychotic first, switch within a class if needed. Clozapine for refractory cases. These are steps and algorithms you should follow. Integration of psychotherapy and medication. Medication without psychotherapy is like prescribing glasses without teaching the patient how to see. Every medication visit should include a supportive microtherapy moment, validation, reflection, and collaborative problem solving. Say things like, "You've handled these side effects well." That shows resilience. Let's review how you're managing stress between doses. Document this. Patient engaged and education provided. These moments build alliance and trust. When going over safety and adherence, at every visit, perform structured safety and adherence checks, screen for suicidality or mania, ask about side effects and metabolic changes, check adherence barriers, costs, side effects, or forgetfulness. Simplify regimens and teach self-monitoring techniques. Use partnership language. Let's monitor this together instead of "you need to do this." Empathy preserves adherence more than instructions ever will. 32-year-old teacher. She returns 3 weeks after starting duloxetine 30 milligrams for anxiety and depression. Patient reports mild nausea, improved motivation, and persistent fatigue. How should you structure your follow-up review? Step 1, acknowledge progress. Your motivation of improving is a great sign. Educate, explain nausea as transient, discuss hydration and timing with meals. Plan, increase duloxetine to 60 milligrams to target residual fatigue and anxiety. And step 4, integrate therapy, reinforce CBT, breathing techniques, and sleep hygiene. Schedule your next visit in 3 weeks for dose-responsive reevaluation. Documentation example would be improved motivation, mild GI side effects, dose increased to 60 for residual anxiety, fatigue, reviewed side effect management, and reinforced adherence. Follow up in 3 weeks. A discussion exercise. Ask yourself, if the patient says, "I'm taking my medication, but I don't feel better," what are your next 5 structured questions? Think through. Is it too early for effect? Are they adherent? Is this dose sufficient? Are psychological stressors blocking progress? Is the diagnosis accurate? Your answers to these 5 questions will determine whether you titrate, switch, or integrate therapy. And key takeaways. Every plan must have a target symptom, rationale, and exit strategy. Follow-up visits should be structured, consistent, and therapeutic. Always assess risk, function, and adherence every single time. Document not just what you did, but why you did it. That's important. In conclusion, psychiatric medication management is not a checklist. It's a dialogue between pharmacology, psychology, and humanity. Each visit is a recalibration of dose, of emotion, and of trust. When you leave this lecture, remember that the best clinicians are not those who prescribe quickly, but those who think deeply, listen, and document thoughtfully. Treatment planning includes every single session, but also a summation should be done once a year to see if you're on a possible good track for the patient. Make sure progress metrics are there and that you're getting somewhere with the patient. Because if you're in a hamster wheel with a patient's care, you often will not retain a patient. If not, you're also harming. So look for those things. Thank you very much and have a good night.